Bonjour à tous. Hello, everybody. We are here for a new complete case in the caecum in a patient with a sigmoid stoma. So it is one of the part of the ESD school with full-time procedure observed and commented step by step. So this is the case of a patient with stoma because of rectal cancer with a second lesion which was in the caecum, very close to the valvula, which is on the right. We are very close to the lip of the valvula, which will appear probably now on the right lower corner. It is not entering into the small bowel, but nevertheless, the lesion is very close to the valvula, and after it goes down on the caecum, uh, coming from the valvular lip and going into the caecum without touching the appendix. So for me, the most difficult in this case is to do the incision on the valvular lip and in the caecum, because if you inject first the anal edge of the lesion will turn to the caecum, and in this case, it was impossible to do a complete retroflexion in the caecum because the scope maneuverability was not perfect. The colonoscopy was described to be quite difficult by the gastroenterologist who sent the lesion. That's why we did not choose the short therapeutic colonoscope pediatric, but a longer one, more stiff one, to be able to reach the caecum quite easily with a relatively good maneuverability. So the lip of the valvula is just on the right, and the lesion is going down into the caecum. So we did first an injection with glycerol mix using a conventional needle. It's better usually to have a needle because you reduce the risk of hematoma while using this. So I re-inject usually with the knife and begin to move from a dot at the good depth. And after, I do my incision, trying to keep the lesion close to the cap in order to control the distance, the margin between my cap and the area I want to cut. So here I can see quite easily the lesion, and you will see I did a mistake in my strategy because probably it was feasible to go further and to achieve the incision on 1/2 of the circumference. But at this moment, I thought I should do first the valvular lip in order to avoid the lesion moving close to the valvula, and I choose to complete the incision on the oral edge, but you will see later that it makes the incision of the left side angle of the lesion more difficult. And finally, I had a regret of doing this instead of completing my distal incision until really the left area of the lesion. So probably a mistake of strategy, and therefore you will see we will have to use adaptation, I mean more difficult maneuver of the scope in order to complete the incision of the left side. So I did this incision here. It's somehow difficult to go downhill. So usually it's more difficult to do an incision by descending than upping, because the scope maneuverability to go up is better than to go down. But nevertheless, it was feasible here to join the two different incision. You see that I'm going too much on the right here, so I could join by going back to the left. It's very important when you are a little lost to remove your scope, take field, and try to understand where is the lesion. So here we re-inject with the knife. The submucosa is quite good. The fatty tissue is not so important for for the valvular area, which is sometimes very fatty. And we could do first incision and complete this incision with a trimming in order to open the space and reduce the risk of having a movement of the lesion through the valvula, which is an area more difficult to deal with if the lesion enter into the small bowel. So here there is a large margin between the lesion and the valvula, but nevertheless it's probably better to begin by this difficult, challenging area instead of doing first the easy and later the more difficult. So you should re-inject again. You see that here the cushion is very good, and therefore the risk of perforation is not important during the incision. Therefore we could push on the knife and do a relatively deep incision from the beginning that makes both the incision and trimming at the same time. So here you will see it's relatively easy until the left area, but unfortunately the way to do for reaching the second part of the incision I did first is not so small, and therefore we will have to do a little more challenging incision, doing down, deflating, trying to re-inject very high volume in order to change the position of the caecum. You can see here, quite impossible to see my first incision. So really, it is an important point. I should have done all the oral edge incision first before injecting at the anal side, because it makes my resection and incision a little more difficult. We could manage to deal with, but once again, when possible, it is easier to do all with a relatively homogeneous and good flow of incision, because here you see that you should find solution. It's not so easy to go there, and therefore it takes a little more time, a little more energy. It makes you less comfortable. So please avoid this by adapting your strategy with the new cases you will do, in order to avoid this kind of mistakes that makes your resection a little more difficult. So you see, I try to inject again because thanks to injection, I can change the macroscopic aspect of the caecum, and therefore it makes the area I want to cut more perpendicular to me without using my down row, which is again not very effective. So if you are able to do it with up without using the down the down row, it's always better. Small hematoma, you can see it here. Small hematoma, which are frequent if we are not deep enough to do the injection. And finally, we will be able to achieve our incision. But you see, everything is not at the same depth, my position is not very good, the scope is not perfectly stable. So once again, it was not the good choice in this case. If there was the possibility to redo it, I will do first all my oral incision with the first incision doing the cecal side first, and later the other one that was really easy compared to this one. Okay, so re-injection again. Once again, I will try to change the caecum to make it perpendicular to me. And finally, thanks to this repeated injection on the cecal edge, we will finally manage to see our second incision and to be able to join the right and the left incision together. It is the most difficult part of the resection. because after you will see once the traction will be set up, the resection will be very easy from the anal to the oral side. But first part is relatively challenging because of this difficult access and difficult maneuverability in the caecum. But finally, deflating and trying to change a little my position of scope, I will be able to finally find again my incision and be able to complete the circumferential incision. You can see the incision on the left area. My point of injection are here. And finally, it will be okay, slowly, because the maneuverability is not good and the scope can slip at any time. So finally, we did it relatively slowly, completing the incision completely. You should not let some bridges like this because it makes the end of your resection not so easy with these fixing points. And therefore, the incision is complete and we will be able now to fix the traction. But unfortunately, the best option to fix the traction would have been to put one of the traction points on the cecal side, but because the clip we use are relatively rigid, more than the knife, you will see that the traction will not be easy to fix on the oral edge, and therefore I have chosen a strategy of 3-point multipolar traction, one on the left side, one on the right side close to the valvula, and one on the anal edge, that make the resection relatively good once the traction system is in place. So there is a little delay here because unfortunately my assistant gave me a pediatric forceps to use the traction device, but it was the one for upper GI scope, not long enough to pass through the longer PCF pediatric colonoscope. So we had to remove the device and use the good small 1.8 millimeter forceps to bring the attract traction device in the area. So unfortunately, 2 times because of the bad device chosen by the assistant, which should be for waste management and reducing of our waste and our device consumed. It is very important before the procedure to try to reduce the number of devices we will use by doing a briefing, for example, to precisely describe what really is needed, what can be avoided, etc. So finally, after 2 different insertion, we will finally see the traction device coming to the area. With the small pediatric forceps, which usually is a foreign body forceps, but used for transnasal scope, that offers the possibility to insert the traction device through a 3.2 millimeter channel. Quite easily. So yes, you're right, it's not so easy to understand at the beginning, but really once you get used to the color and different loops, it is not so difficult to set up. Here we have the good loop front of us, which is one of the 2 fixed points with this blue relatively small loops. We will catch them with a clip which is rotatable by myself. It's very important, if possible, to have a clip that can rotate very easily, or you should a very strong and easy collaboration with your assistant or nurse in order to be able to catch this. Unfortunately, the rotation was not very good in this case because the scope was not totally straight, and it took a little time to catch the loop. Yes, you should try to be precise, and it's a good exercise for trainees to try to keep the good position all the time. So I think in this case, the setup of the device took 8 minutes, but after we have less than 15 minutes of end of ESD. So once again, these traction device, okay, are not so easy to set up, but once the traction is fixed on the good position, it changes totally your game because the traction makes the submucosal fibers totally stretch, easy to cut, and really improve your speed. As you know, in a recent prospective evaluation with this device, we reached a speed of 60 square millimeters per minute on 50 procedures, which is really very high, but it's impossible, I think, to reproduce this kind of speed without a left hand that help the dissection, that help you to make better exposure. So here my goal is to catch either the green loop here or eventually the blue loop which is connected to this because it's the second fixed point. Here it's a little difficult because the loops are a little mixed together. So I decided to bring the device in another place in order to see it more clearly. And finally, the yellow loop not the yellow, but the purple loop was front of me, a little avoiding a good view, but finally I could catch the good loop, truth the purple one, and fix it on the left edge and a little on the cecal side in order to improve it. So first tension is there installed. So you have still a good exposure of the right side because of this two polar traction. But we decided to have a third one on the anal lip because this anal lip will be a little difficult to dissect. So finally we catch the green free loop in order to have a 3-point multipolar traction on the oral edge. You will see it. And finally, we will just have to fix the rubber band on the opposite wall. So first I tried to put it on the cecal side, but the clip was too stiff to manage to go to the cecal side, and therefore I changed a little my ideal strategy of doing a multipolar traction, tracting the cecal side because it was too difficult to reach this cecal incision first. So once again, another solution could have been to do first the cecal incision and immediately put the traction on this area when it was easily visible before doing the injection on the oral edge, because this injection on the oral edge is very good for incision, but on the opposite, make the lesion turning to the cecal side and therefore is preventing a very good visibility of this area. So once the device is set up, you will have the multipolar traction. You should inflate again in order to increase the space. We ask the nurse to bring back the knife and open it, and therefore we will begin the ESD. So first fibers are usually a little touchy to cut because you are afraid of the clear position of the muscle, even if in fact here it's not very close to me, but nevertheless I want to be cautious in this area, open the space relatively slowly, and unfortunately a small bleeding came in this case. So we change the parameters to get RDI um, on the first button. That makes me able to change very quickly from white light, sorry, to RDI. And therefore, it is easier after to control the bleeding when needed. So I wash. In this case, the bleeding comes from the left under the lesion, and it's not so easy to see and to expose. So first, I will still dissect a little, and later, when the area is more open, I will be able to control my bleeding. But trying to control a bleeding without seeing the bleeding point is very touchy. So when you are in a blind area because the bleeding comes from under your edge, please try to dissect first to open the space in order to make your hemostasis more effective by knowing exactly what you are wanting to coagulate and not trying to do it blindly, which is very low efficacy because if you don't see the vessel, uh, it is very small, less than your knife. So getting the chance to coagulate without seeing exactly what you are doing uh, is more chance than really technique. So the best way probably is in this case to open again, open. Yeah. Therefore, you make the area not so blind. Sometimes, because you are dissecting, you will also coagulate the feeding vessel in another area. Uh, and in this case, finally, the bleeding will not be so difficult to manage once you see the vessel, the feeding vessel coming from a deeper area. And finally, I'm not sure I will do the hemostasis of the small vessel coming from the specimen because finally it doesn't disturb me for completing the resection, and I don't spend so much time for treating this kind of vessel coming from the specimen. So here, you should be aware that if I go straight, I can damage the margin of the lesion. So I should go to the right and open more the space. It's the problem when the lesion is turning, a kind of torquing is present, and you have a small risk of damaging the specimen. So you should um, uh, do your ESD in different parts of the lesion in order to create a flat cutting line and not something which is torqued by all the point of traction. But you can see here that it will become very clear once the traction is very strong and once we have removed the initial area which cover the cutting line. And once the space will be enough large, we will go under the lesion in order to have a better exposure of the area. But for this, you should probably deflate. So I decide to go on the right, sorry, and to cut the fibers that are fixing the edge of the lesion, going to the groove, to the circumferential incision groove, in order to open the space. The situation is not perfectly stable, but it will come once we will be under the lesion, clearly. Okay. What you should be sure about is the position of the muscle. So when it is not so easy, please go very slow in order to identify the muscle layer and re-inject blue, because it helps really to see the difference between the muscle and the cutting line of the submucosa. You see it better now. What is blue is what you want to cut, and the whitish area should not be um, cutted very close to. There is a vessel here, so I change for swift coagulation. Although in most of the part I'm mostly using cutting current, which is more precise with less debris coming to the lens. So I really prefer cutting current when it's possible. But once there is a vessel on the field, like here, I will change for swift coagulation and obtain my hemostasis. Thanks to the new ESD scope that are a 6-hour channel, we can go from right to left and later from left to right. It's very uh, pleasant and very good to have the chance of cutting from one side to the other and later from the other side to because you have no time loss because you are always doing something, not doing from left to right and then changing position to come back again on the left. Here you can do both. Right to left, and immediately after left to right. Another point with the therapeutic colonoscope, not this one, but therapeutic colonoscope with a flushing function that goes in the axis of the device, is that you don't have to move when there is a bleeding point. I mean, the flushing function is going exactly on your device, which makes the resection really easier to control the bleeding. In this case, with the pediatric conventional colonoscope, which is a little longer and stiffer for this kind of resection, unfortunately, the flushing function is going around 8 o'clock, although the device is at 6 o'clock. So when there is a relatively big bleeding, you are obliged to change the position of your scope to wash and therefore come back to coagulate, which is not so easy. But now, with the therapeutic colonoscope dedicated to ESD, it's really easier thanks to this water function that goes exactly in the axis of the device. So once again, using a knife with reinjection will change your strategy, because you are not obliged to inject a lot at the beginning and to inject macromolecular solution, because you have the capability to re-inject very, very frequently thanks to the device. We will see here the washing function. When you wash, it's not exactly in the same in the good axis. Fortunately, in this case, because we are under the lesion, even if we don't wash exactly in the axis of the vessel, we will be able to have water coming into the good area. So for this kind of big vessel, I really change frequently for RDI, because I'm a little less lost to see the bleeding point. And despite the fact that this vessel is relatively big with a high flow, because we can be precise thanks to this kind of coagulation mode like RDI, it's quite easy to control it without using an additional device like the forceps. So at least to reduce cost, to reduce environmental burden of our cases, trying to reduce the number of devices and doing hemostasis with the knife itself is almost always possible by trying to be more precise and to really detect the bleeding point thanks to good exposure, cap exposure, RDI, washing, etc. All the new things that are now available to control bleeding that helps a lot compared to what was the scope and devices our colleague from Japan had at the initial history of ESD 20 years ago. So now it's not the same game, thanks of many things, traction, but also device improvement, etc. So here we are still ongoing, trying to always have a kind of facing cutting line. It means that we can, with this kind of exposure, have a long line to cut, which makes the resection easier because you will treat a large surface for any way uh, without spending a lot of time doing small areas. So thanks to this kind of flat um, oral, anal to oral dissection with a large cutting line, you can treat a large surface for every movement and not going back to an area several times. I'm not sure that in this case we will have to tighten again the attract because the exposure is still good. Um, the loop of the attract device are very small and therefore we have a strong traction and sometimes it's not necessary to re-increase traction at the end. It could be helpful because the traction could be better, but the time we will lose by changing for a forceps to increase again will not be saved by a long procedure. So in this case, while the exposure is still very good, I think we will be able to go on the edge and cut the complete lesion without tightening the device. Um, I don't know. I think we tighten in mostly 80% of the cases, but there are some cases where the exposure is enough good and we don't spend time to tighten the device since we will manage to achieve the resection without any new tightening. So finally, um, we will reach the distal edge, and it's very nice to see by transparency the oral side of the lesion because you know that all the thickness of the remaining simosa will be cut and it goes very fast. So here you have the blue, you don't know really how much you can cut, but once you are on the edge like this, you can see in transparent how much you have to cut, and therefore you can go faster by pushing more your knife, being sure that it will not go on the muscle because you are seeing across the remaining fibers how much remain to be cut. I like a lot repeating the same movement because you don't use so much energy when you repeat the same movement several times. So I like this kind of areas where I go from right to left and then to from left to right, but repeating always the same movement. It doesn't ask you to think again. So I really think you save brain energy while doing the same thing several times. And in the strategy, I really like to have this kind of repeated movement to save energy because for example this case was the first of the morning but after we still have 3 ESD to do So saving time, saving energy is always important for any procedure. So just later, I want to close this area. I'm a little afraid of delayed bleeding and delayed perforation, even if we need more data to be sure that it is mandatory to close, and therefore we will use conventional clips to obtain closure. The lesion is here, hanging in the caecum thanks to the traction device that makes also easier to retrieve the specimen because it is fixed on the opposite wall. You don't have to look after. And second point, because it makes the lesion fold on herself, and therefore it's easier to pull it back through the colon because all the points of traction are tracting the lesion in kind of small umbrella, which is like a wallet closed on herself, easier to bring back while descending the colonoscopy. So here we used a clip which is rotatable. We try to fix the two teeth of the clip in the small dot we did around the lesion. First closure will bring a good initial closure, and later we will put again, I think, 3 or 4 clips in order to get a complete closure of the area, which make easier for us to let the patient go back home on the day after the procedure, to reduce the risk of delayed perforation or delayed bleeding, even if this risk is very low when the patient has no anticoagulant drugs. But nevertheless, the cost of the clips in France are not so high, particularly when we use the reloadable clips. And this one, I think, is a reloadable one, less expensive and with less waste, because it's only 4 grams of waste compared to 70 or 86 grams for a single-use clip. So really, even if data are needed to be sure it helps to close, for me, it is still a good way to be more confident about the issue and the adverse event of the procedure. So at least in the right column, I almost close everything. When it reached 4 centimeters, for example, I almost close all my ESD cases. But I'm not saying you should do it. Data for the moment are not really in favor of closure, but we need really a good closure system, probably like Xtac, like Mantis Clip, like new kind of devices to close more easily, or at least doing this kind of small incision all around the lesion in order to make the teeth of the clip um, uh, able to catch the tissue without without slipping, because the main problem when you have a tangential approach like this is to be able to close well the area. So once again, I tried to put my teeth in the small incision I did, because it makes the procedure really easier, and therefore I go to the opposite edge. Sometimes it's difficult to find another small hole, but once you get the second edge of your ulcer, it's really easy to close. So my closure was almost complete, but I prefer to put a last one, I think, on the left. I'm not sure. We will see. No, it seems that I consider it was okay. No need to close more. And last step will be to catch the device uh, with the same forceps. So Once again, we try to reduce the number of devices we use, so we use these first steps to remove the traction clip on the opposite wall, but it's not always very easy because the forceps is relatively small. It is rotatable, so we can use it to turn and but finally, when you catch it well, you can bring it, and you can only pull. uh, it will remove the clip which is fixed. Sometimes it's a little difficult, like in this case, um, because the caecum was coming with me, but finally we will be able to remove it. And we did more than, I think, 2000 ESDs in the column now, and we experience only one delayed bleeding because of this traction of the clip on the opposite wall. So the risk of bleeding or perforation due to this is extremely low, I guess. And finally, we retrieve the lesion fixed with this attract. So it's quite easy to retrieve the specimen because all the points are grouping the lesion, folding the lesion on herself. And finally, we will see the specimen, which was almost 7 by 5.5 centimeter. And finally, it was high-grade dysplasia lesion without intramucosal adenocarcinoma on the specimen. You can see here, despite the fact that there was a nodule at the center, it was not a malignant lesion. Thank you very much for following us and this complete case, which is a little long, but it's reality. I hope it was helpful for you, and please ask questions, please do commentaries, help us to choose the next subject for the ESD channel to help you to overcome your difficulties. Thank you very much, and hope to see you soon on ESD School. Thanks.